Good afternoon. Welcome to the seminar. Thank you for being with us. It's great to see you all. And we have even now for the very first time this seminar with the in-person part at EPFL. So we have real spectators in front of our speakers, which is great. And this is latest counting number 20, talk number 20, since the inception of the CIS Get to Know Your Neighbor seminar series in spring last year. As you know, we try with the seminars to provide a platform of cross-code exchange for our EPFL community. And today we are delighted to have Professor Marcel Salathé with us. Marcel is the head of the Digital Epidemiology Lab here at EPFL and co-founder of AIcrowd. He's further the initiator and co-organizer of the Applied Machine Learning Days. Today he is going to demonstrate the concrete use of the machine learning crowdsourcing platform AIcrowd, and he will also give a brief update on Applied Machine Learning Days. To give you an idea of what to expect, the talk of Marcel will last for approximately 1 hour with a 40 to 45 minutes presentation by Marcel, and then we have time for Q&A at the end. If you have any questions, just put them please in the chat, so we take them up after Marcel's talk. You will also be able to unmute, of course, if you want to ask your questions directly. And for first, the people in the room will be able to ask the question just by raising their hand. Before we dive now into the presentation, I would like to thank Marcel for his availability and the entire CS team for organizing the event. Marcel, the floor is all yours.
Thanks very much, Jan. Good, I hope everyone can hear me. Well, so this is great. It's great to be in a room. Your 3D models are much better than the Zoom 2D. I much prefer that. So here's the menu du jour. I want to briefly just say a few words about COVID, just so that we have this out of the room, right? And since this whole thing is called Get to Know Your Neighbor, it will be hard to know where I am currently without just talking just a few minutes about the COVID situation in the last year in particular. Then I'm going to segue neatly into over digital health and what we are now doing there as a lab. That's another great segue, I hope, to discussions about crowdsourcing and citizen science. And then I make another segue into where I see opportunities there, mostly actually around the second point for EPFL, more as a brainstorming discussion basis. And then as promised at the end, I want to talk a little bit about AMLD, where we stand there, what we plan next, and also, hopefully to get the juices a bit flowing for AMLD 2022, which will be at the end of March. So I don't know how you feel about 2020. This is why I said, a year to fill in the blank. Remember, forget, or any other verb that comes to your mind. Hopefully never repeat, I guess, would be one. My year was extremely chaotic and highly unusual, certainly the most special year of my life, and I hope for the rest of my life that will remain the case. And what's interesting, actually, to reflect a little bit, is that parts of it were completely by happenstance. So in the, I mean, sure, I'm an epidemiologist, and that sort of has certain implications for last year, but nevertheless, what actually happened early last year is, as you remember, we had AMLD 2020, still confused with the years, 2020, at the end of January. We, as epidemiologists, had obviously followed COVID for a couple of weeks. It wasn't called COVID at the time, but this virus, and I was incredibly nervous, right, that AMLD could potentially become sort of ground zero for COVID in Switzerland, and nobody wants that, right? Nobody wants to be the Ischgl of Switzerland, so to speak. Thankfully, that wasn't the case, and then in February, more and more this thing started spreading in Europe. I think most visibly in Italy for quite some time. And what the shocking thing to me at the time was to sense that there was no level of preparedness in the administration. And we can talk about this, and we can maybe talk about it also in more detail in the Q&A, which I understand will not get recorded. So, you know, we were following this with great worry, and sort of the flip of the switch to me came when on February 24th, the head of the Infectious Disease Dynamics unit said that at a press conference in Bern, said that, you know, the expected mortality of this virus is roughly in the ballpark of the seasonal flu, which we estimated at the time to be an error of factor 10. And one should not make an error of factor 10 when one confronts a pandemic, for the simple reason I think that everybody understands now. But the burden, you know, given that about 10% of the Swiss population get infected by seasonal influenza each year, and we expected with the original version of the SARS-CoV-2 virus, a good half at least of the population to get infected if nothing would happen. Now that's completely out the door. Right now we're looking at closer to 100%, but at the time, you know, 50% was a cautious estimate. That was already a factor 5 burden on the system. And then you make another factor 10 estimate mistake. So there, right, we saw something coming to the country that would be a 50-fold burden compared to a seasonal influenza, which I should always remind people, seasonal influenza already brings the system to a kind of a crunch during normal times. So we wrote a letter to the Federal Council and said, you know, we think you may not be, you know, you may be underestimating the situation quite drastically, and we're worried about this. A day later, or 2 days, I happened to give a lecture here at EPFL, and this was completely happenstance, because my colleague Melanie Blockish, who's a professor here in life science, who studies cholera, gives a fantastic course called Infection Biology, and she already asked me in 2019, would you be available to give this visiting lecture, because I'm out of town on the 26th of February. Could you give a lecture in epidemiology or digital epidemiology? And I said, of course, I'm happy to help out. And then, of course, February 26th comes along, and it's clear we have to talk about COVID and nothing else, and this virus. And because of the interest, I decided to stream it and to record it. And eventually some people in the media watched this as well. And that made me sort of a go-to person relatively quickly from the media. And then one thing led to the next. And I ended up being the most cited scientist in the media in this year. That's nothing to brag about. It was actually to some extent a horrible experience, that exposure, but it is what happened. And some things were good, but, and again, we can talk about it maybe in the Q&A if this is of interest to you. But this was not planned, right? It was sort of by happenstance. In any case, this thing starts to unroll, and we start working here at EPFL on this digital proximity tracing, along with colleagues, of course, elsewhere. We realize, you know, the government urgently needs a task force. We call for that task force. In April, end of March, that task force is created, and in April, the task force work begins. And I had the honor of leading there the digital epidemiology group that year. And then in May, as you know, Swiss COVID is launched based on the exposure notification protocol, which is based on the work we've done here. In the summer, as you recall, there's a shift of the control at the executive level of this pandemic, back from the federal government to the cantons. And then in the fall, the pandemic gets out of control again, and it really gets badly out of control. And the country is essentially going through what I now call a kind of eternal October, where decisions are just not taken until finally, towards the end of October, serious decisions are taken, and then the numbers start coming down. But we basically then have to spend the entire winter working our way back in a negative exponential to a more normal situation. And of course, along the way, 10,000 people unfortunately pass away due to COVID. In November, then I began the presidency of the NRP 78 for COVID-19, which is exceptionally running just for 2 years, and will be further, the topic will be further addressed in an NRP 80, which will start soon. Also on COVID-19, but more on the social and economical and psychological aspects. And then in February, I leave this task force and I start another associations. So that's a bit my life in that absolutely crazy year. It's been extremely productive. I was extremely happy with what we managed to do at EPFL in contributing to this technology, which actually works quite well. And I'll show some data later on, and which I think will be likely used in future pandemics as well. But it does come at a severe cost, and I didn't have much time for anything else, and that's of course to the detriment of my own research group. So that's always something to keep in mind. Now you may ask, okay, why did you even do this in the first place? And there was just no way that obviously I could not do this. I essentially trained others later, specifically for the situation. Here I'm just showing you, right, a couple of papers that we've been working on in the past 10 years, you know, where we've been mapping human contact networks based on proximity interactions, right? We've been, you know, looking at the effect of human behavior on disease spread. And you know, finally, this is one of my most cited papers, even though it's essentially a 3-pager, but that's just to show that this field hasn't really taken this very seriously in the past, because there hasn't been that much work on taking human behavior into account. During the influenza A H1N1 pandemic, I also immediately jumped there into the trenches, and we started assessing, you know, the anxiety and the behavioral responses. We didn't have Twitter. Well, we had Twitter, but we didn't really have you know, the kinds of online tools available that we have now. But still, it's something that just deeply interests me. And of course, actually studying how people express themselves about vaccines actually kickstarted my own career, in quotes, as a digital epidemiologist, because that's exactly what we started doing 10 years ago, right? And we still do today, of course, at a much bigger scale. But it is what I do, what I did, I have to say, professionally. This is actually, and this is the last paper I'm showing, my last paper in this area, from the last PhD student that went through my lab, Gianrocco Lazzari, who finished his PhD in 2020. And this paper was published in 2019. And you can see here, right? I mean, this is now stuff that the people back in the day used to really only care if they're epidemiologists. Now this could almost be from a newspaper article, right? Because it says, oh, there's evidence, right, that aerosol transmission is important. But, you know, despite this, most of the assumptions are that it's large droplets. Here we use wireless sensors to measure simultaneously both the location and close proximity contacts in a US high school. And this allows us to model, right, the corresponding effect. And I have to somewhat laugh, right, if I now read this and I read, you know, overlooked mitigation strategies such as improved ventilation, right? And, you know, we were basically looking at this and we were showing the huge effect, of course, that this could have, which is, you know, borderline trivial, but you need to show to people, right, in a concrete model. Strange times. With respect to this technology, we were the first country in the world, right, to roll out the app based on this exposure notification. Now, exposure notification is set up in such a way that you really have a hard time even understanding if this works. It's that privacy preserving, right? It's in many ways a black box. I'm not going to go into the details here, how it works. I'm confident that you've heard in one way or another how it actually works. But it's very much designed so that there's no central oversight over the system. But that's also a challenge for epidemiologists, because now we don't know exactly how we should exactly measure this. Well, of course, we have ideas, and here we are following one of them. But essentially what you have to do is you have to collect data from people once they come into the system. And once you realize, okay, someone comes here, wants a test, is positive or negative, and then you need to ask them, right, were you actually sent here by the app? And this was, critically important information, which was collected in the summer. But then as this fall comes and the eternal October, and the system entirely collapses, not the app, right, but the entire system around it, and this data is not collected anymore. So now we'll never know, unfortunately, exactly how effective the app was. We know it a little bit from this early data. This was the first effectiveness paper also in the world, and where we showed, okay, this works quite well, but we don't have a lot of data because this is based on cases from the summer, of which there were very few. The much better data set later was published in Nature by the colleagues at NHS. NHS had famously held out quite a bit. The English colleagues, England, had held out quite a bit, still wanted to go with a highly centralized system, eventually switched to the decentralized system using this technology, but then really executed it very well and integrated it very well into their local healthcare system, and collected the corresponding data. And you can read this paper, which is now, of course, published. But essentially what this data shows is that in that fall wave, somewhere between 300,000 to 600,000 cases were averted, and about 8,000 deaths were averted just in that fall wave based on the technology alone, and that roughly every % additional usage of the app would prevent roughly 1% of the cases. And it's really striking to me how this has not yet made the rounds in policy circles, right? If we had any other technology that's more classical, right? A molecule that would say every percentage of this molecule that the population takes is a percentage reduction in cases. That molecule would be sent home to everybody, right, in an emergency state. And here we have technology that essentially says the same thing. And the big response in policymaking is roughly shrug. So we have a really strong disconnect between the reality of what technology can do and between what is happening at policy. And that's a bigger discussion that I'm very happy to open, but not in the 40 minutes I have here. Good. Now I'm switching gears slightly, saying, we can talk about infectious diseases all day, and I'm very happy to do that because I did that the last 20 years. But actually, when I came back to Switzerland in 2015 from the US, I said to myself, this is really what I should do in the next 10 to 20 years. And it's not that I don't find it extremely interesting, but sometimes, right, one sort of makes a bit of a bilan and says, okay, is this the most effective use of my time? And if you look at the data, then actually you very quickly realize that infectious diseases are super interesting and for many people really a key issue, but actually non-communicable diseases are the big burden today. And this is why I will come to nutrition in a second. But I want to show this to you in one of these, or a couple of these nice Our World in Data graphs, which I think you're now all quite familiar with because it's such a fantastic data source. But what you can see here is on the x-axis GDP, right, in a log axis, so you get richer as you go to the right. And then what you see on the y-axis is the burden, and concretely so-called DALYs. And DALYs means disability adjusted life years. It's sort of the currency in that field, right? The question is, how many healthy years do you lose? That can either be through mortality, i.e. death, then you obviously lose years, or it can be due to morbidity, i.e. disease, not being healthy, then you also lose such healthy years. So it's not only death, it's also disease. And this is, by the way, this is usually per 100,000. But what you can see here, right, is that this is a huge burden on the poor countries. Here's a slightly different chart, just expressed as the share of burden. And so you can see, right, in poorer countries, this still is about 50 to 70%, right, of all disease burden is due to infectious diseases. And this is what it was also here, right, in Europe, in the US, everywhere. This was just normal 100 years ago, 150 years ago, everywhere. As countries advance and get wealthier, have better healthcare systems and so on, this changes. And what changes, though, is exactly the opposite, which is not a big surprise. This is now the share of the disease burden from non-infectious disease. So now you can see, right, the countries that are very wealthy, now their disease burden is close to 90% due to non-infectious diseases, cancer, heart diseases, metabolic diseases, you name it. By the way, it doesn't quite add up to 100% because there's accidents and things like that. But you can see, right, if you want to do something about the burden of disease, you should in principle, at least in wealthy countries, work on non-communicable diseases, and that's true for most countries, especially as they move up the ladder, if that's an appropriate term. There's a great Lancet paper on nutrition, the EAT study, it's called, and it has this striking sentence there, which I think is in the abstract, which is unhealthy diets pose a greater risk to morbidity and mortality, again, that's disease and death, than does unsafe sex, alcohol, drug, and tobacco use combined. And I recently showed this to another non-scientific audience. They all burst out in laughter because I had to clarify, right? It's not meant at the same time. It's in general, when you add, right, unsafe sex, the burden of alcohol, the burden of drugs, and the burden of smoking, right? You add all of these things, and yet the disease burden is smaller than that entailed by unhealthy diets. And that the scientific evidence today is very conclusive on this, right? That approximately a fifth of premature death is due to unhealthy diets. And that's just death. Again, the burden of disease is, of course, also through being unhealthy, which is the major issue. So I can't go into any great details here, but I want to show you what we're doing in this space, because we're essentially doing two things. We're running a digital cohort tracking one specific question around nutrition, namely with respect to blood glucose levels. And then we're also building infrastructures that others use, and I will show that in a minute. So we're running this digital cohort, it's called Food and You, where we invite essentially everyone. There's some exclusion criteria based on certain diseases, but it's quite broad. In Switzerland, that's the only condition, you have to be in Switzerland. And we then ask them to track the food with an app that we developed for 14 days. We sent them a blood glucose sensor from Abbott. That's it's sold over the counter, so there's nothing experimental. You can easily attach it to your shoulder, upper arm, and it then measures the blood glucose continuously, and you can even in live scan it with your phone and see what your blood glucose level is. We also ask for a stool sample so we can sequence the microbiome, and we also collect activity data. And we don't do this by handing out devices. We simply take whatever they have, and we've in the meanwhile developed a pipeline to already deal with 39 different file formats from Apple Watch, Fitbit, Google Fit, Strava, you name it. We do this in 3 languages, French, English, and German. And it's been running since 2019. And we have now roughly 800 people that have gone through this or are just finishing this now. And the key idea is essentially the following, which I try to show here with emojis exclusively. There's food intake, right? You have a certain diet. That diet gets into your body. where it is obviously chemically processed and has all kinds of consequences. The most interesting of which I find that it can modify your microbiome in such a way that your response to certain drugs, particularly also the interest these days is in cancer drugs, can actually change quite dramatically. But of course, food has all kinds of implications, right? And what I showed here on this running man is, you know, these little green dots there. That's the emoji for a microorganism, right? And the totality of your microorganisms, which by the way exceeds the number of human cells in your body by roughly factor 10. So you're more microbe than human, but you know that's for another day. That modulates your response, and how you then respond. Some, you know, I just showed there a bunch of graphs, right? But the one we're interested in is your glucose level. But you could be interested in anything, right? You could be interested in stress hormones. You could be interested in mental performance, in blood pressure, in weight. I mean, whatever the health outcome of interest. And the key idea, and here you see that I learned today that the two emojis have exactly the same arms and legs. The key idea here is that, you know, the same thing, you can eat the same thing, precisely the same thing. Another person has very different health outcomes there. That's now been shown a couple of times. You know, really throwing out the door this idea that there is such a thing as a healthy food or a non-healthy food item. But the question now is, what actually modulates this mapping, right? What is the algorithm that maps this intake to this outtake of interest? Because if we can find that, then we can obviously reverse engineer it in such a way that I can say, okay, if you show me your microbiome and you give me the thing you'd like to improve or, you know, modulate in terms of health outcome, I can tell you what the nutrition should be. I'm not saying that this is then what you should eat, and there are much larger questions about nutrition than only health, but that's obviously sort of a key idea. We're now also, by the way, starting this pilot of this cohort in Germany. Now, when we launched this early 2019, the EPFL had the following on its website, which was nice and great, and I'm very grateful, but I had to laugh right when I saw the picture, because the picture actually captures something that is really funny and hard in a way. Namely, we have a hard time finding pictures of real food, right? Because that's, you know, that's very nice, but that's your typical Instagram food picture. I'll come back to that. So now, right, we have, this is our distribution of where is this? So you can see this is roughly distributed. There's a bit of an over representation of the Romandie, which, you know, is not necessarily a big surprise. And we started the German version much later, but it's catching up now. And you can see here also the food consumption logged over time, and all of this, right, makes a lot of sense. But we have now over 206,000 food items tracked, you know, with photos and humanly annotated, and I'll come back to that. But this is now becoming one of the most extensive food tracking on record, actually, right, with actual photos and then annotated by humans. And now we are, of course, spending huge amounts of time basically going through this data. One of the things, for example, we found already, but I'm going to cut this extremely short, is that when you go to any other medical cohort and you ask, hey, how, you know, are you interested in nutrition? Most actually in the past used to say, no, not really, right? It's a nutrition, we want, right, gene sequencing and, you know, molecules, that kind of thing, right? And I'm being a bit provocative here, but you get the idea. I mean, nutrition for a long time really had a low standing in medicine. And now recently that's changed. And I think it's mostly changed because of the microbiome findings that are still incredible and coming out by the day. Remarkable findings in how this modulates health. But so then when you go to those that tracked it in the past, they say, well, you know, it's really annoying because basically you have to ask people what they eat and you have to give them these food frequency questionnaires, and everybody hates filling them out and they're not precise. So, you know, we can't really ask them to do that more than 2 days or so. Actually, even the FAO says, you know, you should do it 3 days, right? 2, so you have a bit of variety, and 3, maybe ask on a weekend, right? And then you get some idea. Now we have this record, right, of almost 1,000 people with photographic evidence of 14 days, and we can analyze this data and we can say what do you actually need in order to really track their nutrition. And in our data, we see this is actually 7 to 9 days, after which you don't get much additional information, but every day before you get pretty intense new additional information. And to some extent, maybe again, this jives with your experience and intuition. Most of you, I bet, would try not to eat the same in the same week, roughly, but then week after week, it's kind of forgotten, and that's fine. And you can also see here, as the coefficient of variation goes down, I mean, this just means that we really optimize initially for picking foods that are different from each other, and we try not to repeat ourselves every 2 days or 3 days, and less so every 4 days, and a bit less so every 5 days. So this is a finding that no one else could really show without having that data, and that's not even yet analyzing, right, the activity data, the microbiome data, or of course our actual interest, the outcome in terms of glucose levels. But just to show, right, what a huge diversity on data we now sit on, and that we're of course going to mine the hell out of. It's not important. Here's some microbiome data. The system that we built is actually quite complex, right? I mean, this is the state machine essentially of having to go through the different stages, right? You have then to test the app for 3 days, and then you get questionnaires, and then we link you up with the Abbott Libre view, and then you get the data from there and the tracker, and then you start tracking, and then you have another questionnaire, and then you do this and that, right? You remove the sensor, you lose the sensor. All this stuff, right? We have to send you the material for the stool sampling, right? Without going into the details here. We also have a sub cohort specifically for women to also track the menstrual cycle and see how that influences actually the microbiome. This is by a postdoc in Stanford who was previously in my lab and said, I really want to do this. So it's a complicated setup. You can't just have a student that just takes a little bit of care of a website, right? We've invested at least 4 years into relatively intense development just for the full cohort itself. That's not even speaking yet of the food tracking. So numbers are going up. But you can see here, right, the lost year of 2020 where we didn't do much and it just went up a little bit. Now I want to open a quick parentheses and ask, what's the big deal here, right? I mean, I think this is extremely interesting, obviously from a nutritional and glucose level perspective, and I'm sure, right, there's going to be all kinds of very interesting data that will be unique. But the bigger picture to me is that I think we're actually approaching here something that's shaping up to be the new type of a cohort, right? And cohorts are important, right? Don't forget, almost all relevant medical outcomes and results that we've obtained in the past, 50 to 100 years, but I would say 50, actually come out of cohorts. And cohorts, classically, right, is you have patients go to a hospital, and then hospitals run cohorts, cancer cohorts, diabetes cohorts, you name it. But it's always around a particular disease. And people go there either because they have to go there or they are invited to go there. And then measurements are made on site. Hospitals are extremely good places to do this. Now we're getting into a world, right, where there's new types of cohorts where you don't need a location anymore, but actually the measurements are made on edge, right, as it's called here in this kind of circle, which basically just means, right, you do it exactly in the system where it's happening. It's a sensor you put on, whatever the sensor is, right? Whether it's a sensor in your house, whether it's a sensor in your phone, whether it's a particular sensor that you attach to your body, but the measurements are made there, and that's clearly only going to increase. There is a question, right? At what point a sensor cannot do what happens in a hospital? Obviously, when it comes to fixing fractures and things, I mean, I think we're all clear. But in terms of sensing something that's going on in your body, potentially, right? The sky's the limit there, and we're already now in a world where we can sense a whole lot. And so, when you think about a hospital, right? As I think everybody's gotten now quite clear also in this pandemic, it's really a place for emergencies when you can't deal with the issue at home anymore. Everything else happens outside the hospitals. Every aspect about health, right, happens outside the hospitals. And so it's clear that hospitals are perfect for disease-based cohort, especially for severe disease, because that's what hospitals are built for. But digital cohorts are great for everything else, right? Everything that happens outside the hospital. I mean, I would argue even for severe diseases, because even if you have a severe disease, you're not always in the hospital, but that's, even I think if you forget severe diseases, right? So much happens outside the hospital, and you can collect that data with no need for physical interaction, but it needs a new kind of expertise, right? And that expertise is mostly technological. Of course, you need to know why you're doing what you're doing, right? You need to have that medical background, but then it's mostly the difficulty is in the operation, right? And developing the right sensors, developing the right ways to manage the complexity of a digital cohort, dealing with the privacy issues. And at the moment, my sense is a lot of this is essentially left to industry. And I actually think that a school like EPFL would actually be ideally suited for something like this, right? And many cohorts have started as a small cohort in a particular hospital, and over time have grown to be these massive cohorts. From the Framingham Heart study to the nursing cohort and so on, which started as small cohorts, but eventually gotten bigger and bigger and bigger. And eventually the amount of medical information that could be extracted from that was just mind-boggling. So I'm imagining, right, is there a situation where a school like EPFL could run over many years, right, potentially open-ended, a digital health cohort, studying whatever is of interest in terms of medical outcomes? I mean, that would need to be discussed, obviously, with our medical colleagues. I think this would be absolutely fantastic because, first of all, right, it would give us significant insights into health and also into prevention, which hospitals can simply not obtain because that's not what they made for. It would also provide us with unique research opportunities. I'm just thinking of all the technology that you would have to develop, right, to make this work. I mean, think of digital proximity tracing, which we could have developed before, but we didn't because there was no, in quote, opportunity, right? We would have preferred never to have an opportunity of a pandemic, but there it was, and we acted. Now we're letting these opportunities essentially exclusively be seized by industry, which is fine that they seize it, but I think it should not be exclusive. Think of the privacy technology that we could develop to do something like this in an extremely privacy preserving way. And obviously, right, a school like EPFL is uniquely placed because we have expertise here that's not easily available elsewhere in such a high concentration. And I think it will also be fantastic actually for the students, right, PhD students, postdocs, to be involved in that real world sort of research, right, in their home and on their campus. So I'm going to close this here, and now I just want to be a bit mindful of time because I have, I think, about 5 minutes left. So what I'm going to do here is I'm just going to quickly say a few words about this nutritional tracking and AMLD. So the nutritional tracking is something that's of huge interest to us because we need people to accurately track their nutrition. And what we're doing is we've developed this app that recognizes, right, the food that's on the picture. Now, there's many that are doing this. There's nothing particularly special about that. What's special, I think, is the way we go about this. And by the way, this is just to show that the system is now being used by many cohorts, and we're expanding also internationally. But basically what happens is we're using, obviously, machine learning in the background, but then we're verifying that machine learning by a human annotator on a web platform. And then that information appears on the screen of the user. So there's a delay, but it's not a huge delay for the user. But it has the benefit that the end user, which is the cohort, has a guarantee of 100% accuracy, give or take. Obviously, there's always going to be some misclassifications, human error, but by and large, right, it's 100% accuracy. So we ask people, we ask them in the app, hey, would you be okay to share your food image data with the public? And it turns out, many are, more than half actually. And that's great because we need those images, right, to train the algorithm, because as I said in the beginning, right, food images that you get on the web look like this. When in reality, right, food looks like this. This is from the app, right? It's just not very nice to look at. I mean, you take a picture at home of your food, right? It's almost guaranteed to not look great, but it's delicious food. You're with friends or family or whatever, but you're not going to post it on Instagram because it looks rather ugly most of the time. So, but you need this, of course, if you want to train an algorithm to deal with this. So what we're doing at this point, right, is we dramatically have to improve the algorithm, because the more we improve the algorithm, the less we need human verification, and human verification is our limiting factor. And we're not just going to wait until some company comes along and says, oh, here's an open data set. So we said, okay, we're going to do our own open data set and our own public benchmark. And then whenever we have algorithms that are better than what we use, we actually automatically deploy them. For this, we use the AIcrowd platform. That's from a spinoff from my lab. That's now used by many organizations. We use it as well. So essentially what we're doing is we're giving the public these data, right, that have been made publicly available, including the annotations. And then people can download the data. They can develop an algorithm that is then submitted, right, in code. We take the algorithm, we execute it on private annotated image data that we have, and then we can exactly and in a fair way, right, so meaning equal for everybody, assess how well this is doing. And then we know we can put that on a leaderboard and so on, and sort of kickstart a bit the competitiveness here of the different developers. And then you can see over time, right, how accuracy and recall and precision and so on increases. And then whenever we have an algorithm that's better than the old one, well, we simply replace it, and nobody really notices anything, at least from a user basis, but we notice that things have gotten much better. And that's what we just did recently, right? That we measure how long it takes for an average annotation, because we do this, as I showed, hundreds of thousands of times now already. And this will happen more and more as others use the system. And so we could show already for the first iteration of this crowdsourcing, we could show a 20% time save for the work that we put in. I'm going to skip this. Now, last but not least, a few words about AMLD, as promised. So AMLD is now getting into its 5th year. I hope I have that correct, 5th or 6th. This is now run by 2 full-time event managers that are hired in my lab. The organizational committee is Martin Yaki, Bob West, and me. We've recently created an academic committee that's us plus Lenka Zdeborova, Carmela Troncoso, Mackenzie Mattis, right? You think you know most of them. If you're interested, please join us as well. So you may know this, right? But AMLD has now started to also go abroad. We had fantastic EPFL alumni who came to us and said, we want to bring this to Africa. And they did indeed want to bring it to Africa last September, so just a month ago. But then, you know, COVID also had some ideas about Africa. And then unfortunately, you know, it was planned to be held in Tunisia, which we couldn't do. So it also was an online event, but the idea is now to do it once a year in a different country in Africa. And we're in talks also with other countries. And, you know it a little bit, right? It's now 5 days. It's typically both workshops and tracks and talks. And, you know, we, of course, have major speakers for also, you know, attracting, of course, an audience. But then really we have hundreds of speakers in different tracks. And, you know, there's some of them that I'm showing here to you. And those tracks are actually not organized by us. We call on the community to organize a track inside of AMLD. That's worked well. And then same with the workshops. We have these hands-on workshops where people learn anything, right, that's on offer from, you know, whatever you want, right? There's roughly 30 of them. And startups are now also something that's of critical importance. And you can see a little bit the data, how this has grown, right? We've gone from the first version, which we thought, you know, would be nice if 50 people showed up, where actually 463 showed up. Last year, over 2,000 showed up. And the number of workshops has increased to 31. The tracks have increased to 29. We had 353 speakers. And 2021 was all online. So of course that came a little down, but now we hope to go back to where we were before. So this is my last slide, right? So the next AMLD is going to happen at the end of March in STCC, come what may. Well, with a caveat, but I'm really determined to do this residentially again. And we would like to broaden this ML in AMLD a little bit, right? And take it more from a, you know, learning machines perspective, machines that learn and all the implications, right? From privacy to infrastructure to what have you, policy also, right? Things like that that are actually more soft. And so I just invite you also to reflect a little bit, right? What do we as EPFL actually want AMLD to be? I think there's an enormously important role to play for schools in particular, I see, for centers like the CIS, the C4DT, the SDSC, and so on, and for any lab that is interested. So if you're interested, please contact us or contact me directly if you want. I'm very happy to discuss, but we want to take it to the next level. And I think that's only possible if it really becomes a much broader event at EPFL. Good. With that, I end. Thank you very much.
Just let me say some words of closing. First of all, thanks, Marcel. Very great talk. Thanks to all here in the room and online. Great seeing people in person again. Regarding our next events, we have 3 Get to Know Your Neighbors coming up. This is 4th October, Professor Hamidia, 1st of November, Professor Malamud, 29th of November, Professor Herzog. And then we have a CIS colloquium with Susan Murphy from Harvard coming up 13th December. And last but not least, we are looking forward to hopefully see you all in person for our hybrid EPFL CIS Digital Twin Days on 15th and 16th November. So we have 150 places in person at Swiss Tech Convention Center Lausanne, so get your tickets fast. There's still some available. Thank you very much. Wish you all a great day and hopefully see you next week for Professor Pamidia's talk. Goodbye.